So having talked about the muscles and the joints and the movements of the ankle and foot, now we need to talk about the function. So I want you to be able to identify the intrinsic muscles that give support to the arches, the extrinsic muscles that give support to the arches, and to name the primary muscles that act eccentrically at the foot to control the rate of pronation during gait. Okay, so this is a slide from the muscle PowerPoint, but I still want to mention it. So we're going to talk about extrinsic muscles mostly, and the extrinsic muscles have their proximal attachments in the lower leg or distal femur and distal attachments within the foot. So they have a lot of function during gait, and they have to also provide shock absorption and movement to the lower extremity. So a lot of these muscles are really important in gait. So a lot of the functional considerations we're going to talk about have to do with gait, even though we have not specifically explored the gait cycle yet. So when you advance your foot, during walking, your foot has to, your dorsiflexor muscles have to pick up your toes in order for you to clear your foot. So when your foot drops into plantar flexion during that swing phase of gait, it's because you have weakened dorsiflexor muscles. So paralysis or weakness of the tibialis anterior in particular can result in foot drop. And so a lot of times if someone needs to compensate so they don't trip over their toes, they often use a high steppage gait or high stepping gait, and it's like they're stepping over an imaginary obstacle. The other compensation that people will do is they'll hike their hip or they'll circumduct their leg in order to clear that toe. So you can use an AFO or ankle foot orthosis, which is the brace that's shown in the picture here. It's a rigid AFO to allow, as you advance your foot, it automatically brings your toes up to compensate for that loss of dorsiflexion strength. We'll also use electrical stim to help stimulate the dorsiflexors. We'll do traditional strengthening. There are lots of physical therapy interventions that we do to help strengthen those weak dorsiflexors. Sort of the opposite effect is, so when the dorsiflexors have to contract concentrically to pull the toe up during the swing phase of gait, they then have to contract eccentrically after the heel contacts the ground, so the forefoot can gracefully lower to the ground. So we can land on the heel and roll through the foot. If the dorsiflexors are unable to generate sufficient eccentric activation between the heel contact and the dropping of the foot, the forefoot slaps to the ground, and it's called foot slap because that's the sound it makes when the sole of the foot hits the floor. So so foot drop and foot slap are both weakness of the tibialis anterior and the other dorsiflexors. And so you can think of foot drop as being concentric weakness of the tibialis anterior and foot slap as being eccentric weakness of the tibialis anterior. So both of those we can work on because muscles are our thing in physical therapy, right? So shin splints it's a condition that may affect muscles attached to the medial and posterior sides of the tibia. So it can be posterior shin splints, which is usually mostly the tibialis posterior, or anterior shin splints. A lot of times it happens if someone takes up a new running program or hiking program and your dorsiflexors are untrained or your foot and ankle mechanics are faulty and the muscles become inflamed through overuse. So excessive pronation of the foot during running or walking often exacerbates or contributes to shin splints. So a lot of times clinicians will recommend orthotics to help support the foot and to help take some of the pressure off the dorsiflexor muscles to provide relief. So it's really kind of hard to stretch that part of your body. And a lot of times when the muscles are inflamed, you don't want to stretch them. You actually want to use support to take the pressure off them during your activities. The lateral compartment muscles provide a really important element of muscular stability to the lateral aspect of the ankle and foot. So weakness of the fibularis longus and fibularis brevis, the foot can flip into inversion because the everters can't hold it, resulting in a lateral ankle sprain. You'll also get people after a CVA who have weakness in their fibularis longus and brevis, and their foot turns into inversion as they're walking, as they're advancing that foot. Sometimes you have spasticity in those muscles that makes it a little bit worse, but those lateral compartment muscles are really important for stability in walking. So the soleus is the deeper one of the superficial posterior compartment muscles. It's primarily slow twitch muscle fibers that are sort of our postural control muscles, and they're the marathon runners of our muscles. The gastroc is composed of more fast twitch fibers, and it's better equipped for sprinting and jumping. Because the gastroc is a two-joint muscle, in order to stretch the gastroc, the knee has to be straight because it has to be stretched across the knee and the ankle. So in picture A, she's stretching her gastroc. To stretch the soleus, we have to take the gastroc out of it and bend the knee, and then we can stretch the soleus. So you can think of letter A as being the two-joint stretch, and letter B as being the one-joint stretch. And a lot of times people say that when you bend the knee, they feel it more down into the lower part of their calf, and that is kind of what you feel when you stretch the soleus. So when we raise up on our tiptoes, we're using a mechanical advantage of plantar flexors into that second class lever that we talked about way back in chapter 1. So the plantar flexors provide a mechanical system that favors strength over speed and over range of motion as well. So the body weight is the resistance. The axis is at the metatarsophalangeal joints, and the force is the plantar flexors pulling the heel up. So the plantar flexors are good at this. They're big, strong muscles. So we have our non-contractile features that support the arch, the plantar fascia, and the other muscles on the other ligaments on the plantar aspect of the foot. But if those are overstretched, you could get excessive pronation or flat feet, pes planus. So the deep posterior group, the tibialis posterior, the flexor hallucis longus, and the flexor digitorum longus can help support the medial longitudinal arch. So they're the active portion of supporting that medial longitudinal arch. The structure of the foot and ankle are designed to absorb the impact of weight bearing and to adapt to the shape of the ground. I always say to people in the clinic, our feet and ankles are our first line of defense on balance. We have other things, but let's get the feet and ankles strong first. Dysfunctions of the hip or knee or even the back may be associated with problems originating at the ankle or foot. So a lot of times therapists will start their motion analysis at the foot and work their way up.